Welcome to the Advancing PAH Care video series. This series includes key opinion leaders who discuss new information in the 2022 ERS Treatment Guidelines for Pulmonary Hypertension and how these recommendations can be incorporated into clinical practice in the U.S. Some of the topics to be covered in this series include risk stratification, the right heart beyond pressure, ERS treatment algorithms, and individualized patient care. With support from UT, the PAH Initiative provides non-branded disease education for the PAH community. The initiative worked with PAH experts to identify the content for this program.
Hello and welcome. I'm Dan Lachant. I'm a pulmonologist and assistant professor at the University of Rochester Medical Center. I have both a clinical and research focus in pulmonary hypertension, and I'm joined by my colleague, Dr. Sophia Airhart, to discuss real-world approaches for managing patients with pulmonary arterial hypertension.
Thank you, Dr. Lachant. I'm Sophia Airhart. I'm Medical Director of Heart Failure and Pulmonary Hypertension at St. Alphonse Regional Medical Center and Adjunct Assistant Professor at University of Utah, who we collaborate closely with. I've been an advanced heart failure cardiologist for 5 years and have a strong passion for treating and recognizing pulmonary arterial hypertension. Today, Dr. Lachant and I will discuss how updates in the 2022 ERS treatment algorithm can be applied to clinical practice and the importance of individualizing treatment plans. As you know, these patients are complex and they require a team approach for best outcomes. And that's why we're here as a cardiologist and pulmonologist discussing PH in daily clinical practice. The guidelines focus initially on early identification of pulmonary hypertension in the community, as well as really triaging these patients who are high risk to a center of excellence. With regard to initial drug therapy, 3-strata multi-parametric model is used that estimates prognosis and 1-year mortality and guides treatment with the goal of achieving a low-risk status within the first year of therapy. Early close follow-up is also recommended every 3 to 6 months when a shorter 4-strata model is used that really focuses on functional class, 6-minute walk distance, NT-proBNP. As we know, it's not black and white. Dr. Lachant, what are some of the key factors you consider when managing these patients?
Those are all great points that you just highlighted, Dr. Airhart. The good news is that with new treatment strategies and medications, the outcomes have improved, and I think a lot of that's due to frequent follow-up that you described. Another important point to consider when treating patients with pulmonary arterial hypertension is the comorbidities associated with it. And that's where being at an expert center, and it really helps patients. So whether somebody has scleroderma, cirrhosis, GI bleeding, we have specialists who are well aware of pulmonary arterial hypertension as well as the medication side effects. And also developing strong support systems is extremely important. We provide patients with an emergency number so they can contact us 24/7 if they have an emergency. And finally, the biggest thing that helps these patients is just joining the Pulmonary Arterial Hypertension Association support group system. Networking with patients and families who have been through this journey is extremely valuable and can really help provide reassurance for these patients. These are just some of the factors I think about when managing patients with PAH. Dr. Airhart, is there anything else you would like to add?
You bring up a lot of really important points, and I would like to reiterate those as well. But I start with generic lifestyle recommendations as well as the importance of exercise. So with regard to lifestyle recommendations, I recommend limiting fluid intake to less than 2 liters a day and salt to less than 2 grams a day. But clearly it's going to be patient dependent. I think exercise training is really important, helps people sleep better, it decreases dyspnea, and it improves their exercise tolerance. And are these patients able to maintain medication schedules? You had mentioned maybe inhaled therapy is better for patients. Is it more convenient for them to be on BID therapy? Can they handle TID therapy? Or is continuous therapy more conducive to their life? And so asking all those questions to really find out who they are and how we can best support them is important. Oftentimes, after diagnoses, these patients go online And it can be very overwhelming. And they come back to your clinic the next day and they ask, am I going to live? How long am I going to live? And I think that that is a doorway to have the conversation of risk stratification in pulmonary hypertension and how that informs treatment and why we do what we do in terms of lab monitoring and frequent 6-minute walk tests, so they can be a partner in their care. Also, when patients present at higher intermediate risk or aren't doing the way we hope, we talk about escalating to parenteral therapy, I usually integrate conversations about being considered for a lung transplant, because I don't want that conversation to take patients by surprise, and oftentimes they need to prepare. So there are a lot of nuances in PAH care. Dr. Lachant, as a PAH expert, what is your perspective on the role of PAH centers in managing these patients?
That's another great point you brought up about lung transplantation, and it ties in nicely about PAH centers and experts who treat this. And what we want to do is develop a co-management strategy. The other thing is we also don't want to take ownership of their patients. We like a collaborative approach, especially in patients where it's difficult for them to travel. We like having an option locally for them to be able to still see another provider, have frequent check-ins, staggered visits. And the Pulmonary Hypertension Association makes it easy for patients to find centers across the country. So if they want, they can reach out. And given where we are with the advances of telemedicine, I think all patients should have at least one interaction with a pulmonary hypertension center. And from there, they can decide what's important to them, what the center thinks, what their local physician thinks in terms of who should take ownership of some of their more advanced therapies. Do they need advanced therapies? But that first initial interaction is extremely important for all patients. One important factor in patient care is how to best manage concurrent cardiopulmonary comorbidities. Dr. Airhart, can you talk about how the guidelines recommend managing patients with these comorbidities and how these recommendations align with your current approach?
Yeah, really great question. So when I have a patient in front of me, it's rare that I have a patient just with PAH. Usually they have other chronic medical conditions. And so the first question I ask myself is their PAH due to their other medical conditions, or is this PAH with comorbidities? Well, the guidelines recommend more cautious monotherapy in patients who have cardiopulmonary comorbidities, as well as more close monitoring, particularly because we know these patients with comorbidities have poor response to PAH medications and a greater likelihood of discontinuing medications due to side effects, as well as a lower chance of reaching a low-risk status and a higher mortality risk. Because these patients are at higher risk of side effects, we discuss side effect management proactively, as we do in the PAH population, and I know you do in your population. So really they can be more likely to tolerate therapy and therapy escalation, because their other big risk is that these patients be undertreated. We know that PAH is a progressive incurable disease, and we don't want to undertreat this higher risk population. So that's why frequent follow-up as well as aggressive side effect management is essential. That's my approach as a cardiologist. But Dr. Lachant, I'd love to hear your thoughts from a pulmonology perspective on this complex patient population.
From a pulmonary perspective or pulmonologist perspective, the two tests I really like to look at are pulmonary function test and CT imaging. Most patients have had these checked at some point, and really what I'm looking for is, do they have any airways disease? So depending on what those two tests show, we kind of decide with the patient in collaboration of, is this somebody who I'm concerned medications will disrupt their VQ matching and make their oxygenation worse? And if that's the case and they want to feel better, we typically admit these people to the hospital for 24, 48 hours, make sure their oxygenation doesn't get worse. Then we send them home and follow them up generally in 3 to 4 weeks. And some of our other patients where structural lung disease is less of a concern, we follow a general strategy that you described where we contact them, they keep in contact with the specialty pharmacy, they send us updates, and we generally see them within 3 months to make sure we're headed towards that low risk status.
Thank you, Dr. Lachant, for sharing your experience and insights on the treatment guidelines and how we really need to layer in individualized care plans. We covered a really wide range of topics that require a specialized approach. What are your key takeaways from our discussion today?
Thank you, Dr. Airhart. I learned a lot from you, especially how you view things from a cardiology perspective. And just hearing your experience was very eye-opening and enlightening. Guidelines can help guide treatment choices, but selecting the final treatment should be based on the individual patient situation and needs, and not just following an algorithm. The most important thing I took away was frequent follow-up is the biggest thing, especially for starting monotherapy. We want to make sure that patients are actually improving and we're not just settling for status quo. And co-managing patients with PAH centers has many benefits. And like I said before, I think all patients should have at least one evaluation with a PAH center to make sure everything is the way it should be.
Yeah, I think those are great take-home points. Another thing I would add is that early recognition is really important. And it's important to collaborate with everyone out there to recognize this patient population because they're not all in highly dense areas. And the earlier we recognize pulmonary hypertension, the earlier we can treat pulmonary hypertension, and the better patients do. So thank you everyone for joining us today. It's been a great conversation. Please check out the other videos online as well in the series.
Thank you for watching. This program is part of a series of videos about how PAH management has evolved in recent years. Topics covered in this series include the importance of hemodynamics, the role of risk assessment, the PAH treatment algorithm, and considerations for the treatment of PAH. For more information on PAH, please visit resourcesforpah.com.